So, welcome to all of you. Good afternoon. And we're starting a series of conversations as part of our initiative to demystify medicine, healthcare, and all aspects related to the delivery of healthcare. And these are conversations that we'll have with experts from different fields of medicine, where they'll bring in their experience, personal anecdotes, as well as experiences that are supported by science, the science that they have been practicing for quite some time. In today's discussion, we have two eminent panelists with us. Dr. Rijo Mathew, who is an eminent radiologist practicing in Kochi, who has been spearheading several initiatives in radiology in India and has a special passion and interest in fetal radiology. We have with us Dr. Sailaja, an eminent psychiatrist with several decades of experience of helping people deal with mental issues, and who is, I can confidently say, one of the beacons of hope for many people with mental issues, and she practices at Thrissur. So welcome to both of you. And the topic for today's discussion, the conversation, is focused on fetal abnormalities. And we are looking at how do we diagnose fetal abnormalities as a starter, and then we'll move on to look at how do we communicate the diagnosis of a fetal abnormality to a parent. Pregnancy is a time of celebration. It's a time of joy. It's a time of happiness. And when you find something that is not going well, it gives an element of pain, it gives an element of shock to the couple. For the practicing radiologist who identifies this problem, it's an issue about how they communicate this in a manner that is humane and empathetic to the couple who is having to face this sudden problem in the midst of their celebration. And so to start with, let me ask Dr. Rijo, how do we identify a baby with an abnormality, or how do we identify a fetus with an abnormality? What are the processes that we go through to identify a fetus with an abnormality using imaging techniques?
Okay. So thank you, Praveen, and thanks, Dr. Sailaja, for joining in. And this is a very interesting discussion, very interesting topic that needs several deliberations and different perspectives added from the different disciplines of medicine, from the radiologist perspective, from the obstetrician's perspective, or from all the stakeholders involved in childbirth and pregnancy care. Here we have got a psychiatrist also involved in this, because there are a lot of situations that we come across in our practice where an abnormality, a fetal abnormality is detected, and sometimes and when it is communicated to the patient either by the radiologist or by the obstetrician, there can be a time of grief and sadness, and there needs to be some kind of a mechanism or some kind of a process involved to take care of this period of grief when they face this abnormality and the subsequent consequences related to that. The question that Dr. Praveen has asked me is, what are the challenges or what are the processes involved in diagnosing a fetal abnormality? So in India, India is one of the countries which is, there are nearly 13 crore live births all over the world, and India has got to nearly 2.7 crores of live births every year. And out of these live births, we have got 2.97, nearly 3% possibility of having a congenital structural anomaly. And apart from the structural anomaly, in a pregnancy scan, we can detect abnormalities related to growth and also. So growth abnormalities in terms of preterm delivery, preterm prematurity, low birth weight, all these things can have a lot of issues for the baby, and they also may come across, the parents and the family also may come across a stage of uncertainty, anxiety across in these periods too. But we are now focusing specifically on the structural anomalies. Then there are two areas of structural anomalies. One, it can be related to organs or systems, and two, it can be a multi-organ or a multi-systemic involvement, as in case of syndromes and associations. So right now, before 2000, in 1980, from 1980 to 2000, the ultrasound was the main tool to detect a structural congenital anomaly, and the focus of ultrasound to look for the specific abnormalities in relation to systems of central nervous system, cardiovascular system, musculoskeletal system, chest, abdomen, all these things. We were having a reasonably good idea about picking up abnormalities, but after 2000, we see a considerable increase in the use, in the development of the technologies, even in ultrasound, in terms of color Doppler, the 3D, 4D, and 5D technologies coming in, showing more, giving us more information on the structural anomalies with the help of ultrasound. At the same time, we have started using a combined protocol, combined screening methodology, not only with imaging, but also using biochemical parameters as well as genetic studies. So we have started looking for aneuploidy markers too. Aneuploidies means basically chromosomal abnormalities, commonly known chromosomal abnormalities, Down syndrome. So the search for a possibility of every mother, irrespective of the age, has got a possibility of having a Down syndrome baby. Say, for example, if it is 20 years of age, the possibility of having a Down syndrome baby is 1 in 1,500, which can go significantly up to 1 in 40 or 1 in 50 when the age of maternal age, the mother's age, is more than 45 or so. And similarly, there are some other chromosomal abnormalities like trisomy 13, 18, and trisomy Turner syndrome. All these chromosomal abnormalities also are they are not big in numbers, but can cause significant problems or significant issues to the family. And there are now, after 2000, methodologies, techniques to stratify the risk assessment for aneuploidies also. But much more commonly, if you look at the incidence of Down syndrome in India, it may be nearly 50,000 babies out of this 2.7 crore. But the incidence of other system-based congenital abnormality, whether it's a CNS abnormality or a heart cardiovascular abnormality, musculoskeletal abnormality, they are nearly approximately, we don't have exact statistics coming out from India, but it can range from 7 to 12 lakhs. Accepted this thing from the surveys that we may come across is 6 to 7 lakhs. But including all the minor structural chromosomal abnormalities, it can even go up to 17 lakhs if you consider many of the. But I just want to emphasize here that it may not be possible to pick up all the congenital anomalies, whether even a minor one or even all the genetic syndromes or chromosomal abnormalities with ultrasound alone. So ultrasound, because some of these anomalies are evolving, maybe some abnormalities of the brain, because brain development takes place even after birth till the age of 2. So some of these abnormalities, especially related to the cortical development, can develop even after birth. So may not be able to pick up all the abnormalities in the antenatal period. That means during the period of pregnancy. So right now, the process of identifying the technology used right now to identify maximum number of abnormalities is ultrasound and its various technologies, and using color Doppler, the 3D and 4D technologies also. So right now we have got a ultrasound scan to detect anomalies that can be detected. It can be utilized at 3 months, 5 months, and even at 8 months. Because there are certain anomalies that can develop at 8 months of age in relation to central nervous system, like late onset hydrocephalus or a renal abnormality or some of the cardiac abnormalities that may manifest at a later stage. So we have got processes right now. Fetal radiologists are involved in this screening methodology using ultrasound for anomaly detection of various systems and organs, and also for aneuploidy screening markers, whenever they are detected and the risk of having a chromosomal abnormality is high, we recommend karyotyping or the chromosomal analysis, and that there is a sequential system that is being followed, but not in India. Not every pregnant woman is lucky enough to go through this screening process, because they don't have the facility available, accessibility and availability of the expertise or the equipment is not there. That is why the National Health of Family Survey, this NHFS survey in 2015, revealed that ultrasound uptake, the utilization of ultrasound in pregnancy in India is only 60%. So, but then we have got technologies, the governments and the health officials has to give more emphasis to utilize pregnancy scans to screen for abnormalities and structural anomalies on a larger scale.
So, if I heard you correctly, you're saying that there are multiple ways to identify an abnormality while the baby is growing in the uterus during the course of the pregnancy, and you can do this at different stages. It can be in the first trimester, it can be in the second trimester, it can be in the last stages of pregnancy as well. What is coming out is also that the modalities, even though they are technology based and they're science based and they're evidence based, also has a limitation in that sometimes you may not be able to pick up all the abnormalities due to several reasons. It need not be a skill reason, it need not be any reason that the instrumentation is poor or technique is poor. It can even be that the baby is lying in a position and you're unable to change the position of the baby, and hence you're unable to pick that out. So one of the things that comes up is when you have to communicate this diagnosis, when you have to communicate the possibility that there is a abnormality to the parents, what are the things that go through your mind, or what are the things that you consider when you have to communicate this diagnosis to the parents?
See, when we see an abnormality in terms of a structure, there are two things that I ask myself. One, whether this is a normal variation or a part of a physiological process in the development. One. Or is it a marker related to a genetic abnormality or a development of an organ or a development of a pathology. Say, for example, the fullness of the renal pelvis up to 4 millimeters, it can be a normal variation, can be a normal physiological process, because the ureters, the smooth muscles of the ureters are still to become mature. So there can be a little bit of urine in the renal fetal kidneys, the renal pelvis especially. But if you see a increasing trend towards that, then it can be either a part of a PUG obstruction or a pelviureteric junction obstruction or some kind of a bladder outlet obstruction or something like that. But at the same time, if you see only a mild dilatation it is also considered as a minor marker for chromosomal abnormality. So what I'm trying to say is, first and foremost thinking is whether this is a physiological process or whether it is within the normal limits of that particular period of gestation. And secondly, if there is an abnormality, whether it is a major abnormality or a minor one. So we have, in fact, I have proposed a scoring system to assess the severity of anomalies called as the FIRADS, as the Fetal Imaging Radiology and Assessment, Radiology and Diagnostic Score. So by utilizing the severity score, we can even say whether it is an abnormal. If the outcome, if it can be managed surgically or medically with a reasonable good or a favorable outcome, we categorize them into FIRADS 3. And FIRADS 1 is normal. FIRADS 2 is minor abnormalities, but they may be part of the normal process, or may disappear as the pregnancy advances. FIRADS 3 is mild abnormality, but that can be managed postnatally. FIRADS 4 is abnormality is severe, may require a surgical intervention or some kind of a medical management postnatally. But FIRADS 5 is a lethal abnormality that can have disastrous consequences, fatal, something like a thanatophoric dwarfism or skeletal dysplasia. Like all this will not survive postnatally. Like another condition is a bilateral multicystic dysplastic kidney with severe oligoamnios, fluid reduction in fluid. If you see that, those babies are not going to survive postnatally. We know that. So, and another example is an anencephaly. The skull vault is absent, and those babies are not going to survive. So we can easily categorize them into FIRADS 5 category, which can say that there is a significant fetal abnormality that can have disastrous consequences for the baby. So it is, and there are some abnormalities which can cause significant abnormality for the mother in terms of development of preeclampsia, etc. So this categorization is there. So we just try to categorize in whether they are a normal part of a normal physiological process as the pregnancy advances, or if there is an abnormality that is related, that can be managed with a favorable outcome, that may require serious interventions either antenatally or postnatally, and that can be fatal or with disastrous consequences. And that is how we classify it. And some abnormalities can be multi-system oriented. Those will automatically fall into the FIRADS 4 or 5 category. So there is we can apply this FIRADS scoring system and can counsel accordingly.
Okay, so what is coming out clearly is that there are multiple levels of severity, and the management is also based on multiple levels of severity that you find. There are certain cases which will not survive after pregnancy. There are certain cases that can continue and have possibly a normal life after delivery also. There are certain cases which might need termination of pregnancy, either for the health of the mother, sake of the health of the mother, or because the child cannot survive and continuation of pregnancy might be problematic. How do parents react? What are the challenges you face when you communicate this to the parents? What are the difficulties you face when you communicate this to parents? It's not an easy decision to communicate. Right. It's not an easy decision to take as someone who is expecting a healthy, happy pregnancy and who's built a lot of dreams around it. So it's not an easy decision on both sides. From your perspective, what are the challenges you face when you try to communicate, or when you have to communicate this to the parents?
Yeah. There are two situations most of the radiologists face in their practice. One, because since there are other stakeholders like an obstetrician also involved in the patient care, pregnancy care. Many a times some obstetricians would like them to be informed, and then they will break the news, break the bad news to them. So if we have got a working relationship accordingly, most of the time we may remain silent unless the patient asks specifically the certain questions. But if you are in a referral kind of center where you are, patient will definitely have questions. They will ask what is the outcome, what are the results, and then you have to tell the abnormalities and the possible prognosis of all these things. So the difficult thing is, as I said, if it is a higher category of abnormality, a major abnormality which has got a fatal outcome or a disastrous breaking that bad news is a real challenging situation. And even the FIRADS 4 category, which are major abnormalities that require multiple antenatal or postnatal interventions or surgery for a reasonably good outcome, or the baby may have to live with that. Breaking that also is a challenge. But the other two categories where it's a normal or a physiological thing where we need to watch the baby in the next scan, and we can reassure them. Most of them, they may subside, and let us see whether if it is increasing, we will take a decision accordingly. Then in third category of FIRADS 3 category, if it is a moderate abnormality with can be corrected surgically or with medically postnatally and with a reasonable good outcome. Say for example, a club foot. You might see a club foot, which in the present scenario, postnatal surgeries and the POP cast gives a reasonably good outcome. Maybe in even an isolated cleft lip, or even with cleft lip, cleft palate also nowadays the outcomes are reasonably good. So we categorize them and counsel accordingly. But if it is a abnormality that involves multiple systems, we have to counsel them for we have to get counsel them for a chromosomal test, because we don't know whether a chromosomal anomaly or an association. Now with the microarray tests are available. It's not just the major chromosomes and their numbers are being looked into. We can look into each and every chromosome. So the microarray test also may be recommended in those cases. So breaking the bad news is always a challenge. So what we do is we call the patients, maybe if the bystanders, the husband or the mother, and try to give them a picture. But then this is at that point of time, sometimes their perceptions may be really they may not really understand what we are trying to communicate. So this is the first this thing. But anyhow, we have to say that there is a serious abnormality that requires further consultations, maybe another opinion, second opinion, and maybe you have to confirm it with other tests, or you have to consult and go back to your obstetrician and discuss with them on the further course of management. So what I do is I just give them, if it is serious abnormality, I just give them an idea that it is something that has got some consequences. Then you have to you require multiple consultation. You need a second opinion. You have to go back to your doctor and discuss with them on how we can manage this. And multiple, maybe sometimes we see a hydrocephalus that may require a ventriculoperitoneal shunting postnatally. So I would always tell them that you will have to get a consultation of a pediatric neurologist or neurosurgeon or a neurosurgeon, because they have to pick. And again, they will also counsel accordingly, because as the pregnancy advances, we may not know whether there are other cortical abnormalities or other abnormalities associated with this, whether just hydrocephalus is just a very early manifestation of some other association. So we have to be careful in counseling them. But overall, I feel we discuss with the patient and their husband or mother or parents along with them, and try to communicate. But depending on the level of their perception and education, and sometimes even after all these things, they will ask you, I hope everything is okay. So that kind of challenging situations do come across in practice. But then we try to explain the abnormality. But at that, even with imaging alone, we may not be at a point of conclusive diagnosis. Definitely, this thing. There are some abnormalities like an encephaly or a major cardiac abnormality, like a hypoplastic left heart syndrome. All these things we may not be able to say. But there are many abnormalities where we may require further confirmation for association for chromosomal abnormalities or a syndromic kind of fetus. If the we may have to we may not be able to tell them that this is the end point of all your investigation. You may require other investigations. You may require multiple specialty consultation. You have to go back and discuss with your gyneco obstetrician, and maybe this thing you will have to come for follow-up scans for further assessment.
Okay, so Dr. Sailaja, what's coming out now is that the period of pregnancy, which involved the baby, the mother, the father, maybe their immediate families, and the obstetrician, has now expanded to include the radiologist, and if there's an abnormality, to include multiple other doctors and multiple other processes. There is an element that comes in. All this happiness is now suddenly shifting to confusion, and it's shifting to fear. and there is an element of you have to make a decision, and the decision cannot usually be taken over a longer period of time. The decision is usually within days or sometimes even within hours. Should I continue? Should I terminate? If I continue, what happens? And that whole process at that particular moment for that particular woman can be quite traumatic. How do we how do we help the woman, and how do we help the family deal with such a situation where they came with a lot of expectation? They're happy, they're thrilled, they're joyful, and suddenly the world is turning upside down. And not just turning upside down, it's also forcing them to make a lot of decisions. So how do we help the family? How do we help the, especially the woman who is the home for that particular unborn baby and who has developed a link with that unborn baby? How do we help them to deal with such a situation?
Thank you, Praveen, and thank you, Rijo. It's good to be with you too. Yes, it has been a phase of celebration which turned into a disaster. An emotionally filled situation. Depends on the level of education, cultural background, personality of the mother, the father, and there are other second line people who are equally involved, the siblings of the newborn, the siblings of the to be born baby, grandparents too. In Indian scenario, that is also important. So the decision is not only of the mother. Maybe she is the last person to decide on what is to be done. Just the truth. And there is an element of uncertainty too, even from the medical people. It's an uncertain information that is being given. Maybe we can be so sure up to 80%. Even then, there is an element of uncertainty. And like any other shocking news that you hear, there is Elizabeth Kubler-Ross who defined it as stages of listening to the shocking news. Initial period of shock, and it is not the mother who is suffering, the whole family. Then the shock turns into denial. No, this won't happen to me. I can't accept this. You must have gone wrong. Check again. Then comes the period of anger. All these come within minutes or hours, according to the personality of the person. Then comes the anger period. I have been going through regular checkup. I have been taking my vitamin tablets. I have been obeying all my OBG's advices. Still, why this happened? So anger. And the anger can be towards the pregnant woman also, from the family, including husband or the other children. Then comes the period of bargain with the doctor. Please do something. If it's a wrong thing, just check again. I'll be doing this and that so that this can be reverted or corrected. It happens even with educated people. And then comes the guilt and depression. Oh, I must have got this result because I did that in the past, or I must have done something wrong which gave me this result. And then the final stage of acceptance. You have to accept the situation. You are into that. Now I have to look forward and do or to end with all this. So all these stages in a random order, in random severities. So this is the usual pattern. The psychiatrist comes in only when the grief becomes pathological, or the family becomes so pathologically abnormal. Otherwise, it is usually the brunt is on the gynecologist, obstetrician usually, if at all, radiologist also. Or if there is a usual practice of having a coordinator who reveals all these breaking the bad news thing, the via media. This is almost like a cancer clinic when it comes to negative outcome. It is as good or as bad as that. Let us take it into a humane level. She is, or the family is at a loss when they were expecting good outcome. You are giving them an information that no, it may not be so. We are always guarded. We always say like that. It's not absolute, but then mostly this is going to happen. So this is the expected outcome. So this has to be done. If at all it is correctable, only this much, or this much. Yes, this much you can correct with some negative backups. The ideal situation is, okay, they take you into a paternalistic level, you advise them, they take it. Not at this stage. The Google master is always there, the Google doctor is always there. The next moment, once you say your impression on the radiological status, they go and check. They definitely go for a Google check. They go for a second opinion, definitely. So again, if you are genuine, you can always tell them to take a second opinion. You can always tell them to check. Why not? But then Google checking, you have to caution them regarding the unauthorized informations also. Just like any other bad news of a death or a grief or a cancer or whatever, take it into confidence that you are being genuine. Take them into confidence. They are understanding what you are telling realistically, genuinely. And they will react, maybe in a very, very bad way, verbally or even physically, or harming each other, especially when it is after a very long infertility treatment. These reactions are usually less with a second pregnancy, less with a multiparous woman. This is the finding. And especially when the family support is good, especially when there are other, sorry to say this, but then when there are other handicapped children or persons in the family. And according to the educational status and the level of understanding and the personality, well adjusted personality, the reaction changes.
So, if I may ask, not all of them require a professional psychiatric consultation. Is there a way for us, either at the radiology level or at the OBG level, obstetrician level, is there a way for us to find out who might need professional psychiatric help and who could possibly be helped through, if I may call it as routine counseling? Whether it's a counseling by a psychologist or whether it's a counseling by counselors specifically attached to the departments, and who definitely needs to be referred to a psychiatrist for professional. Is there a way to find that out?
A very practical question. The obstetrician is the one who is so familiar with the lady. Then comes the radiologist, because she must have undergone scanning more than once at least in the first trimester itself. So it's the OBG who can really inform the lady and the family, and she is more authentic than any new person coming into the scene all on a sudden. As the obstetrician knows the person more, she will be aware of a family history or a personal history of a mood disorder in the patient or any psychiatric abnormality in the lady. Family history or a personal history of a psychiatric illness makes the person more prone for an emotional outburst. That to a prolonged one. Then, if you are taking organically speaking, thyroid dysfunctions make the person more prone for an emotional outburst. So, personal or family history and a personality trait which is sensitive or very so-called mentally weak, that way. So that person must be, even the family or at least the couple, to be referred to a professional one. And as we all know, once happened, it can any time recur. And this is a hormonal and emotional imbalanced state. So that person can go into a recurrence. Not only the lady, even the husband. And I had the fortune or misfortune of seeing even the sibling. The boy was in 7th heaven who was expecting a younger one. That person getting into a childhood depression is very difficult. So even the siblings have to be taken care of. So this is the time when a professional psychologist or psychiatrist must come in. Otherwise, a humane approach by the obstetrician or the sonologist will do good to the patient.
Are there any scales that they can use in their OPD or in their clinics that can identify this early? Something that is simple for them to run through, doesn't need complex statistical interpretation. Something simple, gives a score and says, maybe even like the depression inventories.
Yes.
A score more than 12 says that, okay, you need to possibly refer to a psychiatrist or some other scales like that they can use in the clinics.
Yes. There are scales which are used for real major depression episodes. Even for postpartum times, there are scales like Edinburgh scale, or in usual major depression, there is this Beck's depression inventory or Hamilton's depression inventory or hospital anxiety depression scales. All these are anyone can handle, anyone can even judge and diagnose even. There is a cut-off point above which or below which. But in cases of postpartum and post abortion or post information time, there are overlaps of symptoms, like certain physical and somatic symptoms which come in postpartum period or a depression. So they have to be nullified. So actually this Edinburgh depression scale, Edinburgh assessment scale is a good one, a 10-point scale, which you can use even in OP. There is no time consumed, and you on the spot you can diagnose, okay, this person is going into a clinically diagnosable depression. So that you can use.
Okay, so coming back to Dr. Rijo, even though we say that the first point is the obstetrician and the fetal radiologist, in an ideal setting, it is the obstetrician and the fetal radiologist who are the first points. The first point for the abnormality, for the communication of the abnormality, is often the fetal radiologist, because I see it, and the dilemma is, do I tell it to the parent or should I just tell it to the obstetrician and say, you deal with it? I will see the images and I will tell you what it is. At a certain level, you are empathetic, you are humane, and you want to also share this information with the parents and prepare them that something is happening. And the obstetrician might be the person who takes that to a next grade or categorization of a personal interaction with the patient. It's an ideal setting. From a pragmatic setting, practical setting, we know that both the obstetricians and the fetal radiologists are overloaded, because becoming pregnant seems to be one of the things that we are good at. Given our population statistics, that's the one thing that we are good at. And so we are overloaded. And so an obstetrician might possibly be sitting with 50 odd patients or 100 odd patients OPD in that particular day, or even slots of hours. They're dealing with multiple information, and the communication then becomes problematic in terms of the amount of time they're able to devote to a radiologist. And that amount of time depends on each person. Is there a role for a support system or a support team that can help with such a situation where someone can spend time with the mother, with the family, and explain these things in greater detail to an extent that most of their doubts are clear, and can also follow up with them? Do you see a role for that?
I think even before they come for a scan, it is essential, or it is better always to give a larger perspective of what are the possible diagnosis, or what is the procedure, and what are the possible diagnosis, and what could be the implications if we are seeing anything positive out of it. So it is better that we have a genetic counselor or a somebody from the team itself to, or even a radiologist can do it, like they do it in an OPD kind of setup. They can discuss these points before the scan itself, because right now we go through several screening protocols, including for preeclampsia, for fetal growth restriction, for aneuploidy. So we obviously take much of the maternal history, and we talk to the patients, and there may be a BP, height, weight, all these parameters are taken. So we've got a few trained nurses or staff to take care of those things. But even a junior radiologist, or even I suggest even the seniors also should spend time to give an assessment of what could be, how is the test is being done, and what are the possible implications. And if everything turns out to be normal, well and good. If there are any abnormalities, we have to tell them that there is a certain period, like Dr. Sailaja said, there is a period of denial and anger initially, because those most of the time radiologists are the people, if you break the news to them at that point of time, we are the people who has to see these phases. Much before the denial, there is a phase of confusion also, whether they might not have understood what we have tried to communicate. So there is a little bit of uncertainty, anxiety, fear, everything involved, and their comprehension also might not have really gone into the details of what I might have told them about the abnormality. Because that is why many times we see, in spite of all this half an hour lecture on the abnormality on this thing, they will say, everything is okay. So they just want me to tell them everything is under control. So that takes away a lot of time for us to actually communicate. I think this has to be a step-by-step process. Maybe in the initial we have to, before the test itself, if we can say that these are the possible things that we are looking for, and if everything turns out to be normal, perfect, well and good, go ahead, and we'll have we will see you again in the next scan. But if there is anything that is picked up, you may require serial assessment in some cases if the abnormality is not that severe, or if there are certain abnormalities that may require multiple consultations and multiple other tests as part of a confirmation process. So we have to, it is better to give them a perspective before the test, or either during the procedure itself, or in case if you have got some abnormality detected, it is most of the time, unless and until it is a Firat's category 5 very lethal abnormality, where we are almost sure nothing can be done. We are also 100% sure, okay. Otherwise, there is a period of further testing required for confirmation, further consultations required for more information to follow. So we too have got certain limitations, but it is better to have a team involved as part of professionals to give them a perspective before the scan or during the scan, and if there is a bad news, that has to be managed with this proper understanding, as Dr. Sailaja said, that patient may be in a phase of confusion, denial, anger, and the acceptance and sadness, the depression or the sadness and the final acceptance may be delayed in many patients. Most of the time, when we break a bad news, the mother may weep all of a sudden with lot of emotional this thing, and the other relatives who have come doesn't know what exactly. So they all rush in to understand what has happened here. So that can be a little bit of commotion there if we try to, but it is better to manage it professionally with the help of counselors involved in your team, or yourself or your team members. Spend a little bit of time with the patient and their bystanders, and not in the general waiting room. It has to be a separate this thing, because general waiting room, somebody who overhears, everyone may have a comment, and it can aggravate the situation and take it to a level that we even the abnormality may not be that severe itself, but it can take a very different dimension if there are other bystanders or people who are overheard the conversation giving comments and all those things coming in. So it has to be done in a separate space with the help of a counseling team, either from the radiologist or the gynecologist involved.
Just to carry forward from that, the key issue here then seems to be communication. Taking a finding where there's an element of uncertainty and communicating that to the person that, listen, there is an element of uncertainty, but this is what we are finding, and hence we want to look at it further. And this might be the path that this whole process takes you through. And there's an element of coping that has to be built into that. The 2 points that Dr. Rijo mentioned, one is the inclination of everyone to provide an opinion, even if they don't know what's happening, which we seem to be quite good at. And the second is the issue of communication itself. As doctors who have been seeing patients from the younger stages of the medical career, when we have seen deaths, we have seen bad things happen to patients, we have seen severe complications, we have seen trauma, we have seen casualties. The conventional thing is that you know how to communicate all of this. You know how to tell it. But are we really trained, or do we really train our doctors to communicate this information? Or is it just that you learn practice by listening, by looking at a role model? Or do we really train them? Is communication, which is a very element, the conversation today is really bringing that communication is a very key element of the patient-doctor relationship, and the trust that is built between the patient and the doctor. Is that communication a part of our medical education system? Is it something that we are trained at, or is it something that each one of you can find out and figure out on your own and let the patient teach you how to do it better? Your opinions, Dr. Sailaja.
That's a very interesting and practical question. And no, we are not actually. At least we were not. We were not. And there is a change in the curriculum nowadays, adding upon other areas of medical science itself into the curriculum makes it a must that you must learn how to deal with a patient, not examining the patient only. And actually speaking, more than medical curriculum, it's a nursing curriculum which contains this more than anything else. They are wonderful communicators, and they are actually spending more time also with them. We can learn a lot from them. And even those who are trained in communication, like psychologists or psychiatrists, even we are not a better level than most of others. The communication, actually a doctor is supposed to be a teacher also. Every patient who comes to us, they are supposedly they are lay persons, and they are expected to learn certain things from the doctor who is imparting some medical knowledge which is made semi-medical and imparted to them, and they must learn it and change their lifestyle and behavior. So that way we are all doing it. Whether we are doing it in the best possible way or not, no. What is happening is mostly we are using a word of disposing the patient, which is pretty bad. We are not supposed to dispose the patient. We have to take care of his or her complaints, assess it medically, and give a practical solution either through medication or through behavior change, or behavior change of the self or the family or the near and dear ones. That is how it has to be done. Not with the minimum possible time, dispose this person and take in the other person, next person. That is the main thing that we have to change in our own medical behavior. And then, as Dr. Rijo said, stepwise information imparting. Stepwise. That too, I would suggest don't do that with the person only. At least one more reasonable person be there, either the mother or the husband himself or somebody else who can also listen to this. That person may listen to this more unemotionally and process it, and that person can impart this to the lady herself in a better way when at home. No, that is not what the doctor said. It is this, that way. So whatever she has learned she misunderstood, that can be corrected by the family itself. And as Dr. Praveen said, even with long experiences, we may not become better communicators. So better learn that and imagine us in that position, how we will take it, how we would like the doctor to tell us this information or anybody else, how we would like to listen and imbibe the knowledge. That way, do thou. That is how it must be done. I believe so.
Praveen, having said that, there are certain a lot of practical difficulties in the current practice in India, because a lot of patients waiting. Your reception is giving you a hint that there is a lot of patients waiting for the scan. They are restless, and obviously your speed of disposing the patient will definitely, and you won't spend much of your time. You try to communicate, but you may not answer all the questions. Maybe in a psychiatric practice, they are more prepared to spend more time, which is not the usual this thing for most of the other practitioners. It should be ideally like that, but in India, when you got a large number of people waiting in the OPD, and then you're getting the signals from the reception that it is becoming a mess there, you obviously has to send as many patients as possible and reduce the issue around your institution, around your OPD. So there are a lot of practical issues related to that also. I just want to share one funny incident. While one patient I was scanning, my typist asked me about there was an abnormality in the previous case. So I was I dictated it earlier, but she asked a doubt about it, and just I was talking about it and I explained to her. But for this patient, it was perfectly normal. That day, night, I got a call from her husband saying that she's crying and weeping, and there is a hell of a situation here. That she says that you told that there is some abnormality. And I just called my typist, verified this thing. This was a perfect report, nothing abnormal in that. I told him. But then it is my conversation during that time about the previous this thing that has gone into her. And she has made a whole scenario there at their house, and the whole family was panicked, and they were calling me frantically. So all these situations do happen in your practice. You've got a number of stories to tell on all these things. But what Sailaja said is an ideal situation. But given the Indian circumstances, with what we need to understand here, I just want to explain. We have got nearly 3 crore pregnancies here to deal with in India with such a large this thing. All of Europe and all who is giving us guidelines on how to manage each and every patient has only got 48 lakhs of pregnancies throughout the European continent. our single state of Uttar Pradesh has got 52 lakhs live births. So, so the volume that Indian doctors are seeing is otherwise you'll have to give a larger waiting period, and which is again not practical for pregnancy evaluations especially. So I just wanted to highlight this practical issue. Of course, we need to have a guideline, and we need to have a spend more time with the patient, and all these things are ideal situation, but there are a lot of practical issues related to this, because we got volumes here in India to take care of.
Waiting in the foyer with a full bladder, not an easy situation.
Yes, that is true. And also having to sit in a crowded room and listen to everyone talk about everything that is possible, that can possibly go wrong also. It's not an easy experience. Now, the key issues, one of the key aspects that come out here, especially from the last bit that Dr. Rijo pointed out, which is a good point, which I wanted to come to actually, and you made it easier for me, is that people often look at this as a one-sided aspect about how do we communicate this information to the patient, and how do we help the patient deal with this? How do we help them to deal with the enormity of the information that they're given? And the question comes, how much is how much, and how little is how little? And that's an individual decision that the clinician must make based on their assessment of the education, literacy, the ability of the person receiving to take in that information. Equally, what most people don't figure out is that the clinician is also under a lot of stress. The clinician, whether we like it or not, unfortunately, all doctors, as far as I know, are also humans. Whether we accept it or we don't accept it, all doctors are humans. And so they also have their own pressures. And the pressures are not only about the clinical diagnosis and managing to convey this in a human manner. The pressures are also the pressures put in from the external environment, that so many people are waiting. You have to do so many cases. Why are you spending so much time with this person? Now, why is that lady crying there? It's affecting everyone outside. What are you doing? And a whole set of issues around it that makes the whole situation sort of chaotic. And we expect that doctors must be detached and must be objective and must have a calm, clear mind at all times. Expectations are always good, but when we factor in that doctors are humans, and if we understand that, we can also realize that in the midst of all these pressures, the communication can sometimes become a problem. And that's where possibly the help of a team to deal with such issues, a team to deal with this, and a private space for the family to deal with it, a person to sit there with them and talk them through this and give them enough clarity till they achieve it, can possibly help. In an ideal situation, it works. In an overcrowded situation, let's say it's a government hospital in India, a primary health center, a secondary health center, a small hospital, it may not always still be possible to deal with it. What would you suggest is the way forward to make this process a bit more easier for everyone involved? It's open to both of you.
May I?
Yes, please.
Yes, I face this every other day. If I spend 10 minutes more time, 10 minutes more for a single patient, the next patient always asks me, oh, that patient's condition is very bad, right? You spent more time. Or is it so serious that you had to spend more time? It may not be. Maybe it's a first time case, so I had to spend more time, or something like that. Again, as you said, in an ideal situation, you can give them a private space and let them grieve over it, and then you can always give them a second slot on the same day, or if it's possible in the same institution, if it's possible, you can make the OBG also join in and impart the information. That is also possible. to convince the person, actually the presence of the usual OBG will be better, I believe, to convince that person, because she or he is the person who has been with the lady throughout. So when the sonologist says that, if that is added upon by the OBG, and then give a positive note, this is what you can expect, and give the negative outcomes that can happen to the lady. If this fetus survives, what you can expect, is that acceptable? This much can happen, or this much only can be corrected. If that is given, like, sorry to say, the end of life care, that time when we impart the information to the caretakers or the offspring, the same way you can tell the parents and grandparents, like, if this baby survives, this and this can occur in the baby's body or mind or brain or the being. So the quality of life of the person, if the baby survives, or the parent's life, if this baby is there to be taken care of, that gives them a practical implication of the condition. That will help them to take a decision better. Not an emotional one, but an intellectual one. Because every day I am seeing children and not so young children, and not children but not yet adults also. Such people I'm seeing. So there are middle-aged and old mothers especially who tell me, can you ensure that this boy or girl will die before me? Is there a chance for that? How can I leave, especially girls, how can I leave her into this brutal world if I pass away? Actually, I don't have a real answer. So if that is not to happen with this baby, who may not be able to take care of himself or herself, who may not be as normal as the others, who may not be able to withstand the stresses and strains and complications of this world, will it be wise to continue this pregnancy, or will it be good enough? The mental and physical health of the baby and the parents, the quality of life of the baby and parents, that has to be conveyed. For this, not only the sonologist, but the OBG will also be beneficial. Presence will be good. That is my humble opinion on this.
Yeah, what I feel is, from the radiologist point of view, see, it is better to have a counseling team with you, or you yourself leading that counseling session immediately. But there is a period of further investigations required at whatever that you are communicating, and final decision of whether a termination or continuation of pregnancy has to be taken by the parents. As it's a decision of the mother and the basically it's a decision of the mother and the husband. So we leave it to them. And what I used to say is, we are all people who are trying to give you as much information as possible. The final decision, because usually the pregnant lady's parents are the person who will ask you, doctor, what do you think what we should do? So that question will inevitably come in all cases. So all these cases, my answer to them is, see, we have seen an abnormality, and there are some potential consequences of these abnormalities. But at this point of time, this may require some further evaluation with other tests, or may require a follow-up to know whether this is progressing or reducing. And if this has got multiple associations, there's a possibility that this can be a syndromic fetus or a genetic abnormality that may not be easily diagnosed, and baby may have consequences and all those stuff. Or if it's a very serious organ related abnormality, it is there that may require surgical consultations or procedures, and the outcomes can have a little bit of guarded prognosis. All these things we can explain, but fundamentally, I feel we have to give them the information that we are not going to take any decision. Either the gynecologist, obstetrician, or the psychiatrist, or the radiologist, none of the medical professionals are going to take a decision for them. The decision whether to terminate or continue and take care of the subsequent consequences related to that. I always tell that because there are situations in my practice, I can say I've seen serious genetic abnormalities, genetic markers in terms of Down syndrome, and then it was proved as Downs. Even then, parents who are of 45 to 50 years age, they said, even if it is Downs, we are going to have this baby. But unfortunately for them, by 32 to 34 weeks or something, it became an IUD. That's another part of the story. But there, people can react to it not in a way that you perceive that thing. That means you may know that this is a condition that requires termination if it was work. But that may not. There are people who will say that irrespective of this thing, whatever outcome, let it go have a natural course. I have seen patients like that. I knew that, and I have helped them in doing some interventional procedures to reduce that this thing during the antenatal period. But then finally, after the birth of the baby, after a few days, baby might have died, or all these things might have happened. But so it is essential for every professional to understand that we should not give them a decision that, okay, go and terminate it or continue it. The decision to terminate or continue in terms of this fetal abnormality detected has to be taken by the parents only.
So thank you, Dr. Rijo, Dr. Sailaja. It's been an enlightening session, and we have looked at some of the aspects. It's a wide ocean, and we will have more conversations on this, and we will explore more aspects of this. But we have looked at we have started to look at some of the pragmatic aspects relating to the challenges and opportunities and limitations that are associated with the diagnosis of a fetal abnormality and the communication around it, and how to help parents deal with it. It's an important topic because oftentimes, especially in recent times, we believe that technology gives us all the answers. Unfortunately, technology gives us a lot of information, sometimes a lot more information that we need. We still have to declutter that, we still have to break that down, and we still have to pass it on to the parents in a manner that helps them. And many times that's also an overload of information for them to deal with, and so the whole process becomes complicated. So thank you once again for being with us, Dr. Rijo Mathew Choorakuttil, radiologist from Kochi, Dr. Sailaja, psychiatrist from Thrissur, and please stay tuned for more conversations. We will be having them back here. We will be probing them. They're both clinicians who work from their heart, and that's one of the aspects that we want to bring in through the series. Health from the heart, not only from logic, not only from science, not only from rationale and evidence. Health from the heart, combining all of this, building it with your heart, and then saying this is what helps most people, and that's the series that we want to build on. So thanks to all of you who have been listening in. Thanks to our two eminent panelists, and let me say goodbye and good night for today. Thank you so much.
Thank you, Praveen, for choosing this topic. This is a very interesting and a much needed topic that throws light into a different dimension, which often is being ignored. And as you rightly pointed out, the communication of and communication to the patients. Always doctors has to. We were not trained during our medical education in a proper manner on these several aspects, on these behavioral aspects, and how to break the bad news and how to take care of this situation. So it's a very, very, very interesting and new topic that needs a lot of deliberations, and I congratulate you for taking the lead in this discussion. Thank you very much, Dr. Praveen.
Thank you, both of you.
Thank you.